Happy New Year and good morning, good afternoon, or good evening, whatever the case may be, wherever you are. We're very excited today to have my pal and just such a great MPN advocate and physician and researcher, Dr. Ruben Mesa. Each year he does an ASH update for us and for all of you. It was the 66th ASH conference, which just blows me away. There were tons of things about MPNs and lots of exciting news. And so without further ado, I'm going to hand this over to Dr. Mesa, who's now with Atrium Health in Winston-Salem, North Carolina, and we will be going to Charlotte in August. We were in Asheville last August, and we're really excited about this event coming up in August again. And so Dr. Mesa is going to give an update. If we have time, he'll answer some of your questions. And Dr. Mesa, I'll leave it up to you. I can't hear you.
It must have pre-muted me. I hope that you had a wonderful holiday, as well as folks who are online here with us, and excited to share some news about MPNs as well as the updates from ASH. So, for those less familiar, in the hematology world, there are a whole variety of different conferences where people get together, but the largest of them by far globally is the American Society of Hematology meeting. And even though that is labeled the American Society of Hematology, it's really a global hematology meeting with over 30,000 attendees, and pretty much is the most important meeting in hematology around the world. And most certainly the case for MPNs, where there were literally hundreds of abstracts submitted and well over 100 abstracts selected that are presented in posters or presented as oral talks. In the other half of the year, there's the European Hematology Association meeting. That's the other largest congress. That's probably about 15,000 people, and that occurs in Europe. But new discoveries, clinical trials tend to be presented first at one of those two conferences. And then there's a whole series of additional conferences that can be smaller in size. We run one now in the Carolinas with my friend Naveen Pemaraju, Dr. Silver and Dr. Spivak's longstanding meeting in New York, amongst others. And of course, complementing these are the MPN Advocacy and Education International meetings that Anne and her team has put on. These are really meant to be those where there's direct discussion between MPN researchers, clinicians, investigators, and yourselves as patients. So with that, let me jump into some updates, and let me break them into a few different categories. One, there's a tremendous amount of research that was presented regarding the biology of MPNs. Why do they progress? How do we better predict how an MPN might behave for one particular individual versus another? There were a couple of abstracts I would highlight from there that were related to a particular mutation that we have known for a while is a concerning change in MPNs. And these abstracts perhaps really help to emphasize the concern. So particularly with a mutation called TP53. This is a gene normally involved with DNA repair. It's a gene that has been associated with higher risk in a variety of different cancers and increased risk for cancer. And patients with MPNs, particularly if they have a TP53 mutation and additional mutations that seem to really signal a higher risk for patients with MPNs, whether one has ET, PV, or MF, and may suggest the need for potentially more aggressive therapy or earlier intervention. So fortunately, something that is more rare, but all of these sort of discoveries do give us additional insights into both the biology of the disease as well as potentially new targets to try to work on with therapy. So next, let's pivot to essential thrombocythemia. So as a baseline, essential thrombocythemia, too many platelets, there can be an increase in too many white blood cells, I should say. Patients can have symptoms, they can have risk of blood clots or bleeding. We treat almost all patients with a baby aspirin. Individuals that have higher risk, difficult to control symptoms, and higher risk being older, having risk of blood clots or bleeding, having had a blood clot or bleeding event in the past, being over age 60, we will consider using medicines to lower the blood counts. The FDA-approved medicines actually include one, the historical medicine of hydroxyurea, ironically not approved in MPNs, but certainly utilized in MPNs, lowers the blood counts. Anagrelide, which is FDA approved and can help to lower the platelets. Our current NCCN guidelines, this is the National Comprehensive Cancer Network. These are the US-based guidelines, actually recommend as frontline therapy, meaning the first type of therapy we use, either pegylated interferon alpha 2A or hydroxyurea. Pegylated interferon alpha 2A goes by the trade name of Pegasus. It's actually not FDA approved in MPNs, but it certainly is utilized in that and in PV. Now, not at ASH, but I'll mention it today because it just came out in a press release today from Pharmacentia, was the top line data from the study that I and Dr. Serge Versavchik led for them, the SURPASS-ET study. You're hearing it here first, but in these top line results, rho-pegylated interferon alpha 2B, or what is called Besremi, was vastly superior to anagrelide as second-line therapy for ET, both for control of blood counts, elevated platelets and white blood cells, as well as better control of the JAK2 allele burden, suggesting a greater ability to control the biology of the disease. So further results will be coming out as that gets both reported in manuscript form and be submitted for presentation at the international congresses. Rho-pegylated interferon alpha 2B is currently approved for polycythemia vera. So we had strong hopes that it would show superiority as it has in this setting in ET and may lead to greater availability of the medicine for ET. Additionally, at ASH, there was the CALR type discussion. So with ET, there are 3 driver mutations that can be present. The calreticulin mutation present in about 1/3 of individuals, the JAK2 mutation present in about half, and the MPL mutation present in a small number. There was an abstract looking at cellular-based therapy, or CAR-T, specifically against calreticulin, that could be utilized as a specific therapy for CALR mutated ET or myelofibrosis. That mutation is not present for patients with polycythemia vera. There are additionally 2 other medications that are currently in testing against CALR, 2 or more, there's probably more than 2, that are earlier in testing. There was not data presented at ASH, but will be forthcoming. The first is a monoclonal antibody from Incyte that it currently has clinical trials for more refractory or stubborn ET, as well as myelofibrosis, as well as a bispecific antibody from Johnson & Johnson that is in clinical trials. Both of these are available in clinical trials at my center, as well as several other spots. Additionally, there is another medication currently in phase 3 testing called bomedemstat, now being developed by Merck. This is an LSD1 inhibitor that has shown in earlier clinical trials the ability to control platelets in individuals with more difficult or refractory ET, and that is undergoing further testing as we speak. Now, polycythemia vera. Polycythemia vera, in many ways, has a lot of overlap with ET. Tends to be individuals earlier in the course of their disease. Big differentiator is one, most patients with P. vera have the JAK2 mutation, probably over 90%. Second, it's characterized by an increased number of red blood cells, in addition, potentially white blood cells and platelets. It can cause enlargement of the spleen. It can cause symptoms, night sweats, fevers, itching, fatigue. Its therapy starts again with a baby aspirin like we do with ET, but also involves control of the hematocrit. The hematocrit is a percent of blood by volume that are red blood cells. And it has been shown that having a hematocrit of under 45% is beneficial for trying to decrease the risk of blood clots and bleeding, and likely also symptoms. Now, for many individuals, we feel they also need medications to control their blood counts to decrease the risk of blood clots and bleeding, in addition to helping to improve symptoms and avoiding iron deficiency. Frontline therapy, again by those NCCN guidelines, also includes hydroxyurea and pegylated interferon, just as we did with ET. In P. vera, there is a pegylated interferon that is approved. That is that ropegylated interferon alpha 2b that is produced by Pharmacentia. The trade name of Bezremi is approved as frontline therapy for P. vera. Hydroxyurea is also utilized in this setting. Ruxolitinib is also approved. This is a JAK inhibitor. It's approved in the second-line setting. It has been very helpful. It is particularly helpful for people that have very difficult symptoms, itching, night sweats, weight loss, and enlargement of the spleen. And all three of these can have an impact on decreasing the risk of blood clots and bleeding, helping to have an impact on decreasing symptoms. Ropegylated interferon can decrease the JAK2 allele burden, which we feel can have an impact on trying to delay disease progression. And ruxolitinib can have that impact to some degree as well. There was an update at this year's ASH regarding the medication from called the rusfertide, which is a hepcidin mimetic. This is a new type of medication that helps to simulate inflammation and create a state that mimics that of anemia of chronic disease. So to some degree, it kind of mimics phlebotomy and decreases the overall hematocrit. There is an ongoing phase 3 trial looking at that as a way to add it on to therapy to decrease the need for phlebotomies, with the hope of trying to alleviate iron deficiency, improve symptoms, provide more even control of the hematocrit. I'm involved as one of the principal investigators of a trial from the company called Ionis, where this agent is a hepcidin mimetic in a different way. It's working on a different target in that pathway, but with a similar goal of trying to better control the hematocrit without the need for phlebotomy, without the development of iron deficiency. And hopefully this can have a benefit in terms of more even control, more even protection against blood clots or bleeding, improvement in symptoms. So hopefully getting the sense of a tremendous amount of progress and efforts in both ET and PV with overlap of benefit between them, particularly with exciting updates regarding rho-pegylated interferon alpha 2b. Finally, on to myelofibrosis. Myelofibrosis is the least common, but frequently the most problematic of these three MPNs. We estimate roughly, and someone had put this question to me just a few days ago regarding how many patients in the United States do we believe have these conditions. We don't know for certain, but it is estimated somewhere between 300,000 to 400,000, with the majority of those being patients with ET and PV, roughly evenly split. So maybe about 150,000-ish or so with ET, similar number with P-Vera, and maybe 30,000, 40,000-ish with myelofibrosis. Myelofibrosis patients can progress from having earlier had ET or PV, as well as can have primary myelofibrosis as the initial diagnosis. Here, the condition can cause enlargement of the spleen, it can cause symptoms, it can cause anemia. It is a condition that can progress onto acute leukemia or be life-threatening in and of itself. We now have 4 FDA-approved therapies for myelofibrosis. Ruxolitinib approved in 2011, fedratinib approved in 2019, pacritinib approved in 2022, and momelotinib approved in 2023. These are all inhibitors of the JAK-STAT pathway. So individuals, whether they have the JAK2 mutation, which is about half, CALR, about a third, MPL, small percentage, they all can respond because all of those mutations act on the JAK-STAT pathway. And because of that, inhibiting the JAK-STAT pathway has a benefit in any one of those individuals. Now, keep that in mind as we'll talk about a little bit later, a couple agents that are in current clinical trials that are aiming to be more specific for the JAK2 V617F mutation specifically, which has the upside that they may be more effective potentially for those individuals that have that JAK2 mutation, but it may make those therapies more specific to only the individuals that have the JAK2 mutation and make it less applicable to those with CALR or MPL. Now, with those JAK inhibitors, we have first ruxolitinib, improves the spleen and symptoms. Patients who are responding may live longer and have better quality of life. Limiters has been that it's probably not very effective in improving anemia. It can lower the platelet count and has had some side effects, secondary skin cancers, risk of herpes zoster, but overall has been a very, very important and helpful drug for myelofibrosis and really was in many ways a game changer. The second drug that was approved was fedratinib. Overlaps a lot with ruxolitinib in terms of its effectiveness, has some other side effects that we're mindful of. It can impact the vitamin B1 or thiamine, and that needs replacement and monitoring, or there can be side effects related with that piece. It can cause some nausea or some GI-related side effects, but can be very helpful, particularly if individuals had previously tried ruxolitinib and not had an effective result. The third drug is pacritinib. I've been involved with each of these as they were developed along the way. Pacritinib, from the beginning, has been somewhat unique in that it can be used in individuals with very low platelet counts. So that in particular is helpful for people that we say have, quote, cytopenic myelofibrosis, tend to have more low platelet count, more anemia, are more likely to be triple negative, etc. This is approved for individuals with a platelet count of less than 50,000. It's also a consideration for those with a platelet count higher than that, but that's the special niche where it has had its greatest impact, can be given at full dose, improve spleen, symptoms, etc. The fourth is momelotinib. Helpful for spleen symptoms and anemia, can help to reverse transfusion dependence. It is an ACVR1 inhibitor, and it's an inhibitor of hepcidin. We discussed earlier in PVERA that the hepcidin mimetics can decrease red blood cells that are too high. This is the opposite. We block hepcidin, and it can increase red blood cells that are too low. That's been approved since the fall of 2023 and has been impactful really for that reason. And there were a variety of updates on momelotinib, pacritinib, fedratinib at ASH, each of them, again, showing greater granularity to the data, longer durations of response, better improvements in symptoms and quality of life, expansion of activity, and better understanding their use. So that's a really solid group. So what are the unmet needs? Well, the JAK inhibitors are very helpful, and they have their niches, particularly as it relates to differences in blood counts. But they improve spleen and symptoms. And what we've not been able to achieve yet really is complete remission. How do we get the disease to really go away? How do we cure it? How do we help to put the disease, in kind of a sleep mode where it's not bothering you? So there's been a lot of interest in a couple different angles. First, combination approaches, and second, different approaches targeting these molecular mutations. So first, let me mention those molecularly targeted approaches. I previously mentioned with ET the approaches with calreticulin, and similarly, they are being tested in myelofibrosis, both the Incyte calreticulin antibody as well as the bispecific antibody from Johnson & Johnson. And those are too early in their clinical trial testing yet, so we did not have data yet at this year's ASH, but perhaps there will be for next year. They both have had abstracts based on their laboratory data earlier for people with myelofibrosis. Additionally, there are two different JAK inhibitors that are more specific for the JAK2 V617F. So one in a trial that I'm involved with, led by Ajax Pharmaceuticals, that was founded by my friend Ross Levine and my good friend Dave Steensma as their chief medical officer, looking at specifically trying to target the JAK2 V617F. And additionally, there's the drug from Incyte, similarly trying to impact the JAK2 mutation. These therapies, if they reach their promise, may be more effective than the overall inhibition of JAK2. The flip side is that they may be more specific to only those patients that have that mutation, and there be less activity for those, or no activity for those with alternative mutations. The second angle are combination approaches. From the beginning, we've realized that JAK inhibitors were helpful, such as ruxolitinib, but that we still had room to go. They were not cures. Could we increase the effectiveness? Could we increase the durability of response? So numerous things in this arena. First, longer-term data of the MANIFEST-2 study. This was the pelabresib and ruxolitinib trial. I was one of the investigators on this frontline study. It showed clear superiority of the combination over ruxolitinib alone for reduction in splenomegaly, probably almost a doubling. Differences in terms of symptoms, not clearly superior, at least certainly not inferior. And then longer data in terms of durability of response and monitoring long-term safety. There's been a slight increase in some individuals with acute leukemia on the combination approach, And all of this is being monitored, both trying to see both the safety, but also the effectiveness of the combination. To date, it is the most effective combination approach that has been tested in a large phase 3 clinical trial. Additional trials are planned on the route to hopefully an FDA approval. Second, there was data presented in the more advanced phase 3 form with a therapy called naftamatlan. This is from the company Kartos. Serge Verstopchek, legendary leader and investigator in MPNs, is pivoted in his career now and is now the chief medical officer for Kartos. This agent, again, showing really exciting activity in spleen symptoms, molecular markers of the disease, and look forward to seeing that data further mature as a potential combination approach for patients with myelofibrosis. Additionally, there was very interesting data with an agent called nuvisertib that is a PIM inhibitor, particularly helpful in decreasing inflammation, cytokines, and how people feel. I was involved with the analysis and trial, specifically looking at the impact on the profile of proteins in the blood that are markers of inflammation and changes in that profile that corresponded with benefits. Both that agent alone and in combination are undergoing additional clinical trials. In addition to these, there was many abstracts looking at less common MPNs that continue to have progress, such as in systemic mastocytosis and in more rare subsets of myeloproliferative neoplasms. Now, before we open it up to questions, I'll share that this meeting occurred in San Diego, this 66th American Society of Hematology meeting, as Anne had alluded to. It was actually, ironically, in San Diego that I went to my first American Society of Hematology meeting back in 1997, when I was starting my career. And the difference in progress seen in MPNs over that nearly 30-year span is really quite dramatic. When we started, all of the MPN abstracts could be presented in one session. There were, I think, 6 oral presentations and a couple dozen posters. There were no therapies that were specific to MPNs. We had no molecular understanding of the disease. The field was just a few handful of people who are, some of whom are retired, some of whom are still involved with the field. Now we had, at this year's ASH, multiple sets of oral presentations on everything from epidemiology, risk scores, new therapies and outcomes, as well as hundreds of abstracts that had been submitted. This progress is exciting. We know much more about the disease. We have many more therapies that have been specifically designed to really try to directly impact the molecular biology of MPNs. And I think we have a much better way of assessing therapies and seeing their impact. Now, patients that are, there's both a lot of information, but I know as well, interacting with many of you, that the progress, no matter how quickly it comes, doesn't come quick enough. I know sometimes learning about the scientific process, it's a bit like watching the sausage being made. You know, it's sometimes either a little too much detail or it isn't progressing fast enough. I can share with you that everyone in this field, you know, knows the challenges that you all are facing, and very much are doing truly everything they can to try to advance both our understanding of the diseases and the options we have for treating you in the fastest way that we can. And with that, I see that there's a few questions in the Q&A piece here.
Whoops. Yes, if you want, I'll ask them. I have a bunch of them here as well.
Please act as the moderator. Would love that.
Okay, so for someone who is tolerating hydroxyurea well, would you recommend switching to Pegasus or Besremi for the benefit of possibly inducing remission?
So this is an excellent question. When you're doing really well with the therapy, for me, it's a very high bar to consider a change, you know, because what we're really trying to do with the therapies is to try to decrease the impact the disease has in your life. And with that, I judge that in several ways. One, are you feeling well? And that's both, one, if you had symptoms, are they better from the disease? And two, that the therapy that you're on is not giving you side effects that really are a negative in terms of your day-to-day quality of life. Two, are we adequately protecting you against the risk of blood clots and bleeding? So are the blood counts really well controlled or not? And then third, can we help to decrease the risk of disease progression? And there are a variety of ways we can judge that. Are there other evidence that the disease is already progressing some and we're more concerned about progression? We look sometimes at the additional molecular markers in the blood, and if there's more molecular markers, we might have a little higher concern about progression, and then we might consider interferon over hydroxyurea if there's that concern, or there's some fibrosis in the bone marrow, or if the blood counts show features suggestive of a lean toward progression, higher white blood cell count, enlargement of the spleen, etc. So I would say it depends. But there are times that someone is doing really well on a therapy, and it's best that we leave things as they are. Early on in medical school, it was one of my teachers who said, Ruben, you can't help a patient who feels well feel any better. You're only likely to make things worse. So we're always cautious about a change, particularly if people are doing well with the medication.
Okay, the next question, is there a direct link between having an MPN and developing osteoporosis in women?
This is a good question. Not that we know of. Although osteoporosis is so common in women that it's a difficult thing probably to prove. But overall, we have not seen, or I can't say that I've really seen a pattern to suggest a higher risk of osteoporosis. But osteoporosis is so common in our society that, again, probably still good for most women to be mindful of osteoporosis, as well as, again, following their primary care doctor's recommendations regarding calcium, vitamin D, and all of those things that are good for bone health.
Mm-hmm. How would one know when they should seek other treatment?
I think it comes down to, first, how you feel. If something is out of balance, you have difficult symptoms from the disease, or you're having a lot of side effects from the medications that you're on, that's kind of goal one. Now, there are times that there is a change needed that does not translate to you feeling worse. So, for example, there are times that the counts are high and a change is needed. So this is both a fair question for your physician. Sometimes you can feel perfectly fine and still things need to be adjusted. I'll use the example sometimes of high blood pressure or high cholesterol or high blood sugar. Any one of those can give you an increase in risk, but you don't necessarily feel anything different until sometimes something occurs. I use the analogy, it's a bit like driving on the highway at fast speed. Until you hit something, you don't know that anything is off. But if you hit something, it can be obviously bad or catastrophic. Now, if you're confident in your team, then you're on the right spot. When you have a disease that is uncommon, like an MPN, it can be very helpful to have sometimes someone who focuses on MPNs be part of your healthcare team, just to be certain that you're being cared for in kind of the current modern standards for MPN care.
I know that everybody is interested in progression and being able to identify when that progression might take place, or if you are a patient that would possibly progress. So we're looking at German researchers who have published a paper in Nature, and you and I and others will talk about this at another time, but what are your thoughts about genome sequencing in terms of progression, like looking at progression?
Progression is a big concern.
Yeah.
For many patients with an MPN, it's only if the disease progresses that it becomes life-threatening. So disease can do one of two things to us. It can shorten life, it can decrease the quality of life, or both. And likewise, therapies can do one of two things. They can help us live longer, they can help us live better, or both. We do not fully yet know why patients with MPNs progress. This is probably one of the greatest unmet scientific needs. Because once we know that for certain, it will make it easier to design therapies to try to block progression, but two, we'll also be able to better predict who's going to progress, as well as hopefully try to understand if someone's on a therapy, how do we really try to block progression? Now, we certainly have clues. So there are many candidate things out there. We know there's aspects regarding mutations, which ones drive it, which ones not. I view that it's like a puzzle where we don't have all the pieces on the board. We know certain mutations are a problem. I mentioned one of them earlier on in this update with TP53. But you can think it's not just a linear set of switches. It's like a cascade of different switches. And that the pattern of how these things change may be relevant as well as other factors that are within the individual, their level of fitness, sleep, stress, inflammation, comorbidities, other inherited factors such as DNA repair, and other things. So we don't fully know. We have clues. We know that interferons as a clue and decreasing the allele burden as a clue overall probably is helpful, but not perfect. I'll use the analogy, does interferon help to decrease disease progression? I think in a group setting, yes. Meaning, if I have 5,000 people who got treated with interferon and 5,000 who didn't, I'm more confident that the group treated with interferon is less likely to progress overall. But within there may be individuals that don't align with that. Is that every individual? What dose? None of that we can answer. So it's very hard to answer at the individual level more than kind of at the group level.
Mm-hmm.
So I'd say that there's a lot of research going on in parallel, but that is a big question and it's not solved yet.
So do you think one of the questions here, and I'll try to edit it a little bit. So, we all know that hydroxyurea still continues to be a drug that is prescribed to many patients. But do you think that will change over time? Because we do have 4 other drugs that are approved by the FDA now. Or do you think it'll just always be there for some patients?
I think its use will continue to decrease.
Mhm.
You know, for some individuals, it's been a simple and effective therapy. You know, and I would say that the greatest quality of the data, meaning, you know, where is the evidence the strongest for its benefit, has been in ET, less in PV, and in myelofibrosis, I think it's largely really been replaced with the other therapies, except kind of in rare exceptions for controlling high counts. But I suspect as we have more and better therapies, the need for the hydroxyurea will be less. I use the analogy, it's a bit like Tylenol for strep throat. It's helpful. You know, your throat hurts less, your fever may be less, and your body may cure the strep throat anyway, and you're fine. But it still doesn't necessarily treat the underlying streptococcal infection causing the strep throat. So it's not really a true therapy for the underlying MPN.
Mhm.
It lowers the blood counts. It's not a bad medicine. In many patient settings, it gets very maligned, which I think is unfair because there have been a lot of people that have benefited from it,
Mhm.
but it's still somewhat indirect. You know, it's more like, you know, if you're treating the hair, it's more like a haircut. It shortens your hair, but it didn't really change your hair at all.
Okay. And then, so what would you say before we leave? I know your time is precious, and I know everybody would like to know, given the updates, what would you say is the biggest um, or the most hopeful for the MPN community in 2025?
Well, what I think is very exciting is I think we're at the beginning of an era where therapies are going to be able to be more matched with the biology of an individual's disease. Is that CALR? Is that JAK2? Is that how you're affected? You know, I think anytime, even though these are not common diseases, it's still a very heterogeneous group. I can't see the faces of the hundreds of people that are on the call right now, but if I did, I know that some are old and some are young. Some have other medical problems and some have none. Some have a lot of issues and low blood counts, and others have high counts. So it's a very heterogeneous group.
Mhm.
And I think the more our therapies really end up having kind of a stronger biological link to what you're going through specifically, because you don't all have the same disease.
Mhm.
You know, you have a series of diseases that are related to each other, but they're not really exactly the same disease.
Mhm.
So I think the more specific we can get over time, hopefully that will mean less unintentional consequences of side effects because you're doing things that you don't really intend to do. You know, it's a bit like when people use a medicine, prednisone. They use it for one thing, but prednisone does like 40 things. And you get all 40 when you get
Whether you like it or not.
you get the one that you wanted and you get 39 others that you didn't want. You know, and the more we can narrow that, really the better off a medicine is, because then you can be more effective against what you're trying to do, and then hopefully comes with less baggage in terms of side effects.
Yeah. Dr. Mesa, we have so many young people now, and I'm sure you're starting to see more young people, but as you said, the demographic is all over the board. Um, so, for the young people, just one more question. Um, what drug, and again, depending on what their needs are and what's going on with them, but would you say interferons will probably be something that more physicians use with MPN patients that are younger?
Well, I think it definitely should be a strong consideration. The interferons are the younger you are, the potential advantage of the interferons are greater
Yeah.
in that there's probably a lower risk of disease progression. Additionally, they probably are safer for use, particularly of women of childbearing age, because although no drug is perfect during pregnancy, we have fair confidence that interferons can be used safely during pregnancy versus the other drugs. So those are a couple big pluses in the mix. I'd say as well, as it relates to being younger, one, with MPNs, you'll read that, the average age is 60, and one, I think the key to realize is that the distribution of patients is not that everybody is around 60. That's an average. You take the United States and the average isn't too far off from 60. So one, it's much flatter a distribution than you might imagine. So the patients I see in clinic, again, go from teenagers to 90s, and that it's more distributed. And two, I do think because of all the reasons that we check blood counts these days, pre-employment physical, going into school, pregnancy, there are more times we find elevated blood counts in individuals because of secondary reasons. So are we having more as a society, or whether we're finding more? There's probably some degree of both.
All right, so thank you. And we will see you possibly before this, but our event in Charlotte is on Thursday, August 21st. And we're making those arrangements. And that was so much fun in Asheville. We had such a great group, including you. And we'll bring some of those people back. And so thank you all for joining us. This was recorded and we will send it out tomorrow. And we thank you very much, Dr. Mesa, for your time and for your expertise and input always.
Delighted to be here. Thanks for all you do, Anne, and look forward to seeing everyone in the Queen City.
Oh, yeah. Okay. Thanks. Hello to your family. Bye now.
Bye-bye.